So the last one is Owen Samuels, who's going to talk about acute stroke. Owen helps direct the neuroscience program at Emory, has been instrumental in creating the neurocritical care program and creating programs around stroke and subarachnoid hemorrhage at Emory. So Owen, I welcome you to talk about intervention in endovascular therapy.
Hey everybody. I've built my career talking to try to localize and schedule my talks right after lunch where everybody was postprandial and sleepy or not going after particularly smart people. And I've broken both of those rules today, unfortunately. There was a great talk by Adam and Tommy. Greg and Micah had asked for me to talk about acute stroke intervention in 15 minutes. So I split the difference. I gave the slides in your syllabus as an hour lecture, and I'll only be talking for no more than 45, right? So stroke is very interesting to me. It's what we're all afraid of and what we all desperately want as we age, to know that there's an acute treatment out there. And when I was asked to give this talk back in the fall, I was kind of bummed. I said, can't I have Adam's talk or Tommy's talk? Because really, we had experienced a few years of extreme disappointment in acute intervention of stroke, and I'll get to that in a couple of minutes. But what I'm going to try to do in the next 15 minutes or so is really a 20-year journey. Really, that began in my residency when I was, as a resident, enrolling patients in the NIN-TPA trial. I have no disclosures. So stroke, as we know, time is brain. You've heard that in buses throughout Atlanta and everywhere else. In general, you have an acute ischemic core, which is very unforgiving. Let me see if I can work this. And effective stroke treatment tries to save everything around the ischemic core. And if this is all you have left, then you're probably ahead of the game. If you have nothing left, that's great. But this clock is up here for a reason. Just like many other things that we're learning about in critical care, time does matter. Sepsis does matter. Acute stroke does matter. MI does matter. So at the end of the day, there are really two main keys to success in acute stroke management, as we'll talk about towards the end. One is speed and the other is teamwork. And then you could say that that applies to many of the things that we do in critical care. The difference between stroke and MI, they're both ischemic syndromes, but the heart, as I joke around with my cardiology friends, is a simple muscle. Doesn't have a lot to do other than to pump blood to the brain and the body. The brain, on the other hand, does lots of different things. It's much less forgiving than muscle, certainly. And you can have strokes by many different mechanisms. You can have a blockage in the brain. This is basilar stenosis. You can have a clot in the heart from AFib or cardiomyopathy. You can have coronary stenosis from atherosclerosis and dissection. And you can have atherosclerosis of the sub 1 millimeter arteries in the brain called lacunar stroke. Probably they all respond somewhat differently to different stroke treatments, but we don't know what they have when they first come in. Well, first, when someone comes in with neurologic symptoms, it's always the ABCs, as always, and a CT is the study of choice, as you all know. About 15% of them are not going to be an ischemic stroke, and you can't know that until you get that scan. So you can't pass go to start down the interventional or non-interventional ischemic stroke treatment until you can be sure that there's not a hemorrhage. They've done studies that the most astute clinicians and the best chief residents and residents, can they tell the difference between a hemorrhagic stroke and an ischemic stroke by examining the patient? And the answer is absolutely not. Maybe except for my two fellows down there, they might, but the rest of us can't. So ischemic stroke is, again, has the largest proportion of all stroke. And then we're going to spend the rest of the next few minutes talking about thrombolysis, thrombectomy, embolectomy, endovascular advances. We never really know what the mechanism of the stroke is, whether or not it's AFib, cardiac disease, coronary disease, whatnot, until after we reach treatment. So we're not depending upon knowing the mechanism of the stroke for the intervention immediately. Again, there's modifiable and non-modifiable risk factors. Unfortunately, we can't change our age, we can't change the stroke severity, but you can change revascularization, blood pressure, glucose, temperature, as Adam talked about just a minute ago, stroke unit care and rehabilitation. All these things do have enormous impacts on stroke. In general, not hyperglycemia, not hypoglycemia, but euglycemia is in general the target. There's been a fair amount of data that low blood sugar is worse than high blood sugar in the setting of ischemic stroke. Temperature is bad no matter what. Unfortunately, there's not been interventional trials to suggest that lowering or maintaining blood sugar or maintaining euthermia has an independent effect on stroke, but common sense being common, this is what we do. But revascularization really is the key for urgent treatment of stroke. Interestingly enough, the primary endpoints in stroke trials are not mortality. Right? There are things worse than dying, which is living in devastation. So the Rankin score is a relatively simple score that really anybody can assess. A Rankin of 0 is neurologically normal, and a Rankin of 6 is dead, and everything in between is grades of severity. In general, we'd like to be normal. That would be the primary endpoint of stroke, but that may be unrealistic. So in general, most of the interventional trials have a Rankin of 0 to 2 or less than 3 as the primary endpoint. And I say that now because this is what we'll be talking about going over this myriad of clinical trials. Well, what doesn't work in stroke? What I was taught, I don't know if Tommy is here, but Tommy trained at Mass General, and Mass General in the neurology world stands for must give heparin. Aspirin doesn't work in the acute treatment of stroke. It does have a role in secondary prevention, somewhat of a modest role. Heparin does not work. 10 to 15 years worth of data. Heparinoids don't work. Unlike in our cardiology colleagues, I was a big fan of TB3As many years ago, but that doesn't work. This is the only thing that works. Acute thrombolytic agents, whether it be intravenous or more recently intraarterial, and endovascular clot retrieval, which we'll spend a lot of time talking about in just a minute. Well, these are a representation of some, not all, of the intravenous trials over the years. This is 1995 was when this really became very popular, the NINDS trial. But these are the two trials that really have established the standard of care treatment for intravenous TPA. The NINDS trial, which was published in 1995, established a 3-hour window, which is FDA approved now, and has been for many years. ECAS-3, which followed ECAS-1 and ECAS-2, was the European trial, which established efficacy of IV TPA and extended the window to 4.5 hours. So 4.5 hours is still good, but again, there is a dismal proportion of patients that present even within 3 hours or even 4.5. And again, the limited efficacy of these has made the field look for a better treatment, which is endovascular, which I'll talk about in a minute. Well, this is just some of the data from the original NINDS trial, and they had a lot of different outcome scores, but the Rankin is one, and there's about an 11 to a 13% increased probability of having a Rankin of, a Rankin of 0 to 1, meaning normal or near normal. There is, nothing's free in life, as everybody knows, when you give thrombolytics to anybody, but there is a 6% approximately. More recent data suggests it's probably a lower than 6% risk of an intracranial hemorrhage. But if you're the one unlucky one that has an intracranial hemorrhage, you've got about a 50-50 chance of dying. So it's low, but it's serious. Well, there are a lot of limitations to IV TPA. The treatment window, as I say, is limited. It's a systemic bolus. You want to direct that direct that thrombolytic treatment or whatever treatment directly to the clot, not everywhere else. We don't really know who benefits, and we know that there's a subgroup of patients that really don't benefit very much at all. These are patients with carotid occlusions, terminus intracranial carotid occlusions in the brain itself, M1 occlusions, basothrombosis, and patients that are refractory to thrombolysis. Terminal carotid occlusions, and MCA occlusions have a mortality upwards of 60 to 80%. So again, here's a patient. This is the carotid artery coming up for the neck. This is the anterior cerebral artery, and here's a stump of the middle cerebral artery, which feeds approximately about 80% of the blood to that hemisphere. This is after getting direct intra-arterial treatment. This is a slide from a patient that actually I was involved with at Grady in 1997 or 1998, and there was complete recanalization, and the patient did well. Now, recanalization does not necessarily mean good outcome, but it's certainly a step in the right direction. This was done out of a randomized, placebo-controlled, drug-sponsored study called the PROACT-2 study, and a serine protease of urokinase was the drug. And this was a home run. This was a 15% absolute difference in terms of a ranking of less than or equal to 2. 60% relative benefit. Larger strokes also benefited, which is the strokes that are 11 to 20 in the stroke scale, which is an enormous, devastating stroke. The number needed to treat was 1 in 7, and the recanalization rate was 67%. I mean, this was a high-five home run in 1999, but it did not receive FDA approval because it was just one study, unfortunately. So the routine care often included IA-TPA because pro-urokinase was not a drug available, but it was done out of the setting of a randomized trial and probably delayed the progress of acute stroke trials for a decade or even longer. One of the limitations of the PROACT-2 study was that only 67% of the vessels opened up. So you have a lot of vessels that stay closed, and that most likely contributed to only a 15% difference in outcome. If the vessels opened up and you got to them within 6 hours, which was the time limit here, you'd expect a much larger clinical effect. So that ushered in industry to see if thrombolysis is only opening up 60% of these vessels, then how do we do better? So many endovascular companies that spent their time in the coronary world switched over or added the neurology world and looked to devise all sorts of clot retriever devices, and now there are several on the market and they're FDA approved. This is the Mercy device that was originally tested in 2005 by Wade Smith at UCSF and Jin Sung at USC. And this was not a randomized trial. This was taking PROACT to the next level and saying, can we open up safely occluded arteries in the brain within an 8-hour window, which is what this study, this was a non-randomized, certainly non-controlled trial. This is a basilar occlusion with a mortality upwards of 80%, if not recanalized. This is the recanalization. This is after IA thrombolysis did not work because of whatever that clot was made of. And here you see the thrombus that the Mercy device pulled out. So recanalization certainly is a requirement, but not sufficient for a good outcome. Well, these are the vessels that we're talking about. We're talking about, here's the vertebral artery in the neck coming up, intracranial vertebral artery, and the disease typically is at the top or sometimes the middle of the basilar artery. This is the carotid circulation, this is the bifurcation, and it's these occlusions right here, proximal M1 occlusions and intracranial carotid, that are absolutely devastating. The second publication for the Mercy device was in 2008, and again, this was not a randomized trial, but what it did establish is that the vessels will open. That's what it established, but it certainly did not get FDA approval for a clinical outcome, but it did get FDA approval for its ability to open up blood vessels, and that will tell you the difference between the FDA approving a device versus the FDA approving a drug. Very hard to get drugs approved, relatively easy to get devices approved. So for better or for worse, this was approved, and then it was open to the whole country to use this in a case-by-case intervention in the absence or outside of a randomized trial, for better or for worse, and most of us think for worse. So this is, as of 2009, these are the trials, PROACT-2, which we talked about initially, IMS-1 and IMS-2, other trials, the Mercy, and then more Mercy in the Penumbra device. And you can see that these vessels, these techniques or these devices do open up blood vessels. But as of 2009, there was really one study that was a randomized study to look at the benefit of intra-arterial therapy, whether that be intravenous or mechanical embolization. So fast forward to 2013. 2013, there were 3 articles published in the New England Journal of Medicine. Synthesis, the expansion study, IMS-3, which was a bridge of IV to IA embolectomy, as well as device, as well as thrombolysis, and the MR rescue study. I'm not going to spend a lot of time on them, but these are the 3 trials. They all were variations on a theme. Some of them had imaging inclusion criteria, others did not. But again, they were all randomized, controlled, blinded studies looking at, in general, a 6-hour window, looking at standard medical therapy, which is intravenous thrombolysis, versus intraarterial intervention. And unfortunately, all of them were negative, which is why I was bummed when Micah and Greg asked me to give this talk, because I said, what am I going to talk about, 3 negative studies? And that's really not going to be very cheerful. So this is how I felt. I don't know if anybody's basketball fans, but this is probably how our friend from Miami felt before he went over to Cleveland, back to his home. 3 negative trials, negative for primary outcome, and an all-time disappointing year. And actually, I give this sort of metaphor because his team lost, right? He didn't lose. The Heat lost. So this was sort of a team failure. And those 3 trials failed because of team failure, not because of an individual prognosis. And there's been a lot written about it. My old mentor, Mark Chimwitz, wrote an editorial about this, of why those 3 trials failed. These were trials that an enormous amount of effort. They used older, less effective endovascular devices. That was one possibility. The randomization was prior to confirmation of an arterial occlusion, which was probably one of the biggest problems. They did not include, or some of them did not include, severe strokes, which is where this endovascular intervention would benefit from. There was a longer window between the onset of stroke and treatment, and we know, as we say, time is brain. They had a very disappointing low recruitment rates, and the likelihood is because these devices were being used sort of in common practice. And there was a lack of a rapid and effective imaging method. So we're not going to talk a lot about diffusion and perfusion mismatches on CT and MRI, but actually, if you're trying to treat someone whose brain has already died, then obviously you're not going to succeed. So trying to actually find that sweet spot for a person that actually has salvageable brain can be very important. So again, flash forward now, 2015. Most of us came back from the stroke meeting on a high, because this was a banner year. 2013 was a bummer year. This was a banner year where 4 trials were presented, Mr. Clean, Escape, Extend A, and Swift Prime, 3 of which have been published in the New England Journal of Medicine, and there were several other trials and some interesting data that was presented there as well in terms of acute stroke intervention. And I do not have time to go through all of them, unfortunately, but this is the Mr. Clean trial. You've got to love these names. But this is the Mr. Clean trial, and this was a 6-hour randomized trial looking at, again, standard of care, IVTPA, 3 to 4.5 hours, and then the other half were randomized to that plus endovascular intervention, again, with a more current device. And the modified Rankin, which was the primary outcome in favor of the intervention, was 32.6% of patients at the end of 90 days had a Rankin of 0 to 2. Again, that would be moderate disability, but can be independent in their life, versus 19%. And the number needed to treat went from 1 out of 5 down to 1 out of 3 patients. And this was a really big home run. This is just a table from the graph looking at the Rankin score, Rankin of 0 to 1, 0 to 2, and 0 to 3. And these are all kind of home run in terms of intervention versus control. And if you look at the intracranial occlusion follow-up in terms of vessels recanalized, the difference is extraordinary, between 75% and 33%, and the infarct volume went down, as you'd expect, because the Rankin improved as well. Next trial was the Escape trial, which was, again, another randomized trial. Again, all 3 of these trials were non-American trials. This was a Canadian trial, the first one was the Netherlands trial, and the last one is an Australian trial and New Zealand trial. But again, same effect, number needed to treat was 4. This was actually a 12-hour window. It was a 12-hour window because they used the imaging criteria to really look at the sweet spot of salvageable brain versus brain that was a foregone conclusion. And again, intervention versus control was a home run. 53% had a Rankin of 0 to 2. That's a very high number for severe strokes versus 29%. And again, the NIH stroke score at 24 hours was significantly different as well. Across the board, the outcomes were really spectacular. And the last trial that has been published is the Extend A trial, and this was a Australian and New Zealand trial. Again, this used a very modern intracranial device called the Solitaire FR. And again, they looked at, again, the difference between, this was a 6-hour window as well, and the effects were equally statistically significant. So this is a summary of the randomized placebo-controlled trials for endovascular stroke from essentially from 1999 to 2015. We have PROACT, which is sort of the granddaddy of all these trials. Back in 1999, there was a significant improvement. Number needed to treat was 7, but no change in mortality. And as you can see, none of these are powered for mortality, nor is that, would be nice to be a goal, but again, it's functional outcome rather than mortality is the endpoint. One of these trials, which was the ESCAPE trial, actually did show a significant change in mortality. But we have Mr. Clean, met the endpoint, yes. ESCAPE, yes. Extend A, 1A, yes. And the SWIFT Prime, which has not been published yet, to my knowledge, but again, was a market success. And the number needed to treat are pretty powerful, anywhere from 1 in 3 to 1 in 7. So this is how I would summarize acute stroke at our place, at Grady, which is at, the mecca of acute stroke management, at least in the Emory area. And anywhere else for that matter. So someone comes in with a stroke within 4.5 hours. The CTA shows the vessels are open. That could be a small vessel stroke. That could be an artery that is in the process of recanalizing. That's IV TPA between 3 and 4.5 hours. First, obviously, the stroke alert gets set off. 911 comes. Emergency transport. Hopefully, they call the ED as a heads up. The stroke pager goes off. The CT scan is ordered quickly. And the time to needle hopefully is under an hour, and hopefully even less than that, even 45 minutes from the time they hit the door. You get the CT, you diagnose an ischemic stroke. If it's a hemorrhage, obviously you're going down a whole different line. Are they IV TPA eligible? Because there are exclusion criteria that need to be followed carefully. And if the answer is yes, they get IV TPA. A large artery occlusion, yes or no? If it is yes, then you are in a different category. Then you're getting IV TPA. And if you're at a comprehensive stroke center or a center that's sophisticated, then you're eligible for an endovascular intervention. Again, that's, if you're now 4.5 to 6 hours, then IV TPA is out, whether it be 3 or 4.5 hours, but endovascular is certainly a possibility if you have an occluded artery on the CTA or the MRA, if that's what you've gotten, typically. Now, can you extend the window out beyond those 6 hours? Well, possibly, depending upon the center that you're at and depending upon whether or not they have image-guided, really thoughtful stroke treatment as was presented in some of the more recent trials in terms of looking at a mismatch of perfusion as well as diffusion-weighted imaging or CT imaging, CT perfusion. It's possible that you can even extend that window out to there. Now, you should know that between 4.5 hours and 12 hours, none of this is FDA approved yet. These trials are brand new. This is literally hot off the presses. I think we were at the meeting about a month ago or so. But I think we're going to find that the recommendations are going to be out very shortly within the next year regarding an update to the American Heart Association, Neurological Association guidelines. So in conclusion, the primary stroke centers are obviously essential. They can give IV TPA, and they can hopefully rapidly transport patients elsewhere to comprehensive stroke centers. The comprehensive stroke centers in our system are the Marcus Center at Grady, which Adam runs, as well as Emory University Hospital, and we were among the first as a system to have comprehensive stroke center. But when you have that, you need intravenous and intraoral techniques, image guidance, neurocritical care, and certainly neurosurgical support for hemicraniectomy, clot evacuation, and other kinds of intracranial pressure monitoring. The challenges, well, there are many challenges, but 2 of them are really pre-hospital delays and inter-facility transfers. I mean, that's enormous. We can only treat patients that arrive at our door, so how can you speed that up? Well, we don't have this in Atlanta, but this was first started in Germany, which is kind of cool, and now it's in Houston as well as Cleveland. And these are mobile carts. Ambulances equipped with CT imaging as well as teleradiology or teleneurology, I should say. So patients literally can be treated with intravenous TPA en route to the hospital. And actually, now there are a few publications documenting the efficacy. One of these costs about $1 million. And these are the most recent guidelines, which were published in 2013, but there's been enormous change between 13 and 15. Again, the FDA hasn't recognized that yet, but that will be forthcoming probably in the next year or so. And that's it. Thank you very much.